And welcome. It is September 9th, Tuesday, 2025. I'm Dr. Duke Majan. Our patient is a nurse. She travels here because she has 2 discs that need surgery. She did not want fusion done. She was offered invasive surgery by other doctors, which is typically what happens. And she learned about the endoscopic Duke laser disc repair, which has been around for 20 years, folks. She came here, and that's what we're doing today. She's got 2 discs that are herniated, degenerated. First thing I'm going to do is displace the trachea and esophagus over and the carotid sheath and its contents. Then I'm going to verify my location. My God, look at how thin her neck is. 2, 3, 4, 5, 6. I'm going to go a little bit further south towards her feet where we can encounter 6, 7. We've had many nurses over the years come here because they don't want traditional spine surgery. 2, 3, 4, 5, 6, 7. Now, she did have neck pain. She does have neck pain. We had to treat her facets as well. Let's get a shot. All right, so shot. Wow, I'm not even really in. Shot. Let's get a AP, see where the tip of the needle is. At this moment, I'm displacing trachea and esophagus, one side, carotid sheath and its contents to the other. Okay, so that's perfect, lateral. You can see the staples in the back of her neck from her facet treatment, the rhizotomy we did. Shot. All right, I'm going to have to just, let's see here. Shot. I'm going to come south. Shot. Shot. All right, looks good. Shot. You agree at 6, 7? Shot. AP. Let's just make sure we're in the middle. Quickly. My fingers are starting to suffer a little bit. And we are. Lateral. If you have questions, feel free to ask me. In the meantime, while we finish getting this needle in, let's show our audience the 30 causes of neck pain. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. You can see on the X-ray image, the AP, we are in the 6-7 disc through the front. You can see the endotracheal tube and the esophageal temperature probes. So I've displaced the soft tissues over to the side. I've gone between the carotid sheath and its contents on the lateral side and trachea and esophagus medial into a small space between them, which is the same space we normally go for invasive surgery like ACDF, except we're going to do this through a 4mm incision. And you can see the dye is leaking out on both sides through a tear in the back of the disc. At this point, I'm going to make a small incision to do her surgery. This is a 4mm incision, 4mm. And the surgery, there will be a little bit of bleeding, about maybe a few drops of blood, but that's it. There's no hospitalization needed. Shot. And you can actually see on the lateral view, shot. Let's, all right, what is all that? That's our Raytech shot. That's better. You can see the needle. You can count. Let's count. C2, 3, 4, 5, 6, 7. You can see an osteophyte in the front of 5, 6 at the anterior margin there. Yeah, so we're at 6, 7. We're doing the lower disc first. I'm going to take the needle out, leave the guide wire, and I'm going to place a dilator. The dilator is extremely thin and narrow, but this spreads apart the tissues. It doesn't cut anything. We're not cutting. The only thing we're cutting is her skin, and it's a 4mm incision. You guys see that? 4mm, maybe 5mm. It's tiny.
Yes, we do.
Shot. I'm going to hold the guide wire so it doesn't accidentally advance. I'm going to twist the dilator down. Now we're at the front of the spine. I'm going to enter her disc. Shot. Now I'm right at the bottom of the C6. Thank you. Yeah, you can tell it's sticky. The ice of you makes it sticky. Shot. Let's get another AP just to make sure that we're in the middle where I want to be. You need to be not dead center, but you want to be as close to dead center as you can on the AP view before you go in the disc. And then we're going to go off to the side. That's perfect. You can see the spinous processes in the middle, and we're right in the middle. So we're in the middle between the two longest colli muscles. We are pretty much at the center of the spine, just in front of the ALL, anterior longitudinal ligament. I'm going to take the guide wire out. I'm going to advance the dilator into the disc. We're going to go to the back where the tear is. You see the tear? Show us the tear. You guys see the tear right there at the back of the disc? There it is, the black line. That's the tear. We're going to the tear. What? Nope. Not on her. Maybe the next disc. Shot. We're going to go to the back of this disc where the tear is, where the herniation is. Thank you, Dr. Brendas. All right. Perfect. So we are there. Wait. Now, folks, check this out. This is a 4mm wide tube. The entire surgery is going to be done through this 4mm wide tube. That's it, right there. Endoscopic spine surgery. It's funny because I go to the national meetings. I went to the one in Boston, and they have a few endoscopic neurosurgeons who are just starting to do endoscopic spine surgery. We've been doing it for 20 years. And they think that they are the shizzle, and all they do is lumbar. They haven't even touched cervical or thoracic, which is much harder than lumbar. Lumbar is like child's play compared to cervical and thoracic. They may get there in another 10 years. We'll be 30 years ahead of them.
What if they watched any of our videos?
Sean? And then they won't even touch thoracic. I'm sure they're watching our videos. I'm sure they're watching our videos going, how the hell does this guy do this? Okay, that's where they are. But they are the golden childs of neurosurgery. They're fondled and coddled by organized neurosurgery. They are controlled like little marionettes by the people that control the strings of neurosurgery, the very powerful companies that control implants. And they're on a very short leash. They're only allowed to do treatments that benefit the implant company. Sean? So what's happening, you see that? It's loose. That's why it's making that tapping sound. What's happening is there's so much pressure inside this herniated disc that it's pushing my dilator back. Look at that. I have to put it back in. I cannot just advance the tube without the dilator. Otherwise, you'll biopsy the disc. You do not want a disc biopsy shot. It is bad. At this point, though, it might not be bad. It might be okay. All right, we're there. So we did it. We are now with the tip of our tube inside the tear, right where the herniation is. We're going to use the laser to debride the tear. There is no metal. There's no fusion. There's no artificial disc. That's why this procedure has not been adopted by the majority of neurosurgeons, is because there is no fusion or metal, and that is where the big money is. If you're a spine surgeon, if you're a neurosurgeon, your biggest dollars come from spine surgery where you put metal in patients, like fusions and artificial discs. That's the big money, and that's what they all want to do. They want to make the most money. They're not thinking about what's best for their patient. They're thinking about what's best for themselves, the surgeons, the hospital, the anesthesiologist perhaps as well. Our anesthesiologist, on the other hand, wants to do what's best for the patient. That's why he works here. It's not for the pizza lunch, right? It's not for my charming personality, or is it? I'll let you decide. There's the laser. That laser fiber is literally 0.5 millimeters. Really, it's 0.45 millimeters, but who's counting 5/100ths of a millimeter? All right, now we're at the back of the disc herniation. That is herniated disc right there, you're seeing.
What happened? Why?
What's going on?
I was going to say it's for the sharing the same ideologies and beliefs about patient care. Did you hear that noise?
Yeah, there's nothing coming through the fiber. So we're going to change our fiber. In the meantime, I'm going to reach down with a grabber. What's that, Dr. Berndes?
I was saying it's for sharing the same ideologies and beliefs about patient care. Share the
Yeah, well, every doctor goes to medical school. No, I'm good. You know, saying, oh, I want to take care of patients, do what's best for the patient. And then they become a doctor and they realize that there are many influences besides what the patient needs. There's the hospital, what the hospital wants, which is the procedures and treatments that make them the most money and cost them the least. There's the biomedical device companies that want to stick their metal in patients. That's how they make money. So they're telling surgeons to do that. There's the insurance companies who support invasive surgeries and treatments that don't work because they want the general public to believe that there's no treatment that exists that's actually beneficial, so that people stop getting surgery done, even though the surgeon tells them they need it. And that way they get only the most desperate of people to have treatment, which saves the insurance companies a lot of money, okay? Imagine if everybody had access to this treatment, then everybody would want this treatment. They wouldn't want to live in pain. They would get this done because it's covered by their insurance. Any questions?
Yes, we have a good amount of questions. These first two are coming from Samir on YouTube.
Welcome, Samir, to our live stream.
First question asking, Doc, have you ever had any issues with neck surgery with endoscope? I am a little concerned about not removing the full disc, which is pressing the nerve. One doctor told me that going from posterior is the best.
So, yeah, first of all, the best surgery in the world is not posterior for the disc, ever. Posterior is the worst, okay? Why? Because the herniation that's causing the symptoms is right here. You guys see the blue right there, Samir? That is the herniation that's pinching the nerve. And it's not the whole disc, Samir. You don't need a discectomy. Okay, they lie to you and tell you you do. But that's because they only know how to do a discectomy. They don't know how to do this very elegant surgery. This surgery is known by only a handful of spine surgeons. The best spine surgeons in the world know how to do this surgery, including myself. Of course, I've done 1,000 disc removal surgeries in my career, putting in cages and artificial discs, and metal plates. I used to do that all the time. I'm probably one of the best in the world at doing fusions of the spine, if not the best. And I don't say that because of me. I say that because of my results. It's all based on results. And that results, I'm talking about patient results. What the patients say after surgery. That's what matters. It's not what matters what the x-ray looks like. It doesn't matter what the MRI looks like. It matters what the patient experiences. In other words, if the patient's strength comes back in their arm and their pain is gone 100%, that's a good result. That's the result I want. I don't want anything else. I don't want to look at the MRI and it shows a good result, the disc is gone, but the patient is still having a lot of pain in the same place they had before surgery. That's not acceptable to me. I want to fix their pain. There's a piece of herniation right there. Did you guys see that pop out from where the nerve was?
Yes, we did.
That just popped out of the foramen. How's our pressure? Because I'm not floating these guys out very well. That is a bigger piece, but I guess the pressure's okay. So that piece doesn't want to float out with the water, the irrigation. I'm going to have to go grab it and take it out. Then I'm going to have to put the grabber in. And there it is, right there. You guys see that?
Yes, we do.
That piece right there. It's not big. It's only about 2 or 3 millimeters, but that's the inside of the tube is 2.8 millimeters, so that was about 2.8 millimeters. Didn't want to come out. All right, here is the problem right here. You're looking at the tear in the back of the disc called the annular tear, and you're looking at the herniation stuck within the tear. That's the blue stuff right there. And I'm using the laser to remove it, but I'm not putting metal. I'm not putting plastic. I'm not putting cadaver. I'm not putting PRP or stem cells. All completely unnecessary and counterproductive. Bad for the patient. Good for the surgeon and doctor who make money. Good for the companies that sell it, but not good for the patient. Remember, everything we do should be what's best for the patient, not what's best for the doctor. There's the foramen. You guys see it down there? And
Yes,
that's probably the nerve root and the dura around the nerve root. So I'm removing the herniation out of the foramen. You guys see that?
Yes, we do.
That big piece of herniation was pushing on the nerve, and now it's going to be not pushing on the nerve. It's going to be gone. Okay, there's another piece right there. The point is, you don't need to remove the whole disc, Samir. You only need to remove about 5% of the disc. And that 5% is the 5% that's left the disc and is pushing on the nerves. All right, what's going on, guys? What? You guys are so funny. Every time we do one of these surgeries, it's like rediscovering bacteria or antibiotics when it comes to figuring out why is the irrigation leaving and getting on the floor. Every time. Look at that. That's a big piece of herniation. You guys see that? Look at that right there.
Yes, we do.
That is, wow, that's a long one. It's about a centimeter long, about 8 millimeters, but it's skinny. Skinny and long. Okay, and that's what we do. We just take these herniations out from the back of the disc. This was taught to me, this concept of leaving the disc there, but only taking out the part in the back that's causing the problem, which is the herniation. That was taught to me by Dr. Seng-Ho Lee, who is a Korean neurosurgeon, South Korean neurosurgeon, and Dr. Gun Choi. He was the first in the world to do a selective, what's called a herniactomy. Go in and take out the herniation, leave the rest of the disc. Prior to that, every surgery I did was a discectomy, where you take the disc out. Now we do herniectomies, where we take the herniation out. Only the herniation. Much better for the patient. And we leave the disc there. There's nothing wrong with her disc. It's working just fine. Any other questions?
Yes, this next question, excuse me, from Samir, once more on YouTube. asking also, how long do I have to wear a collar after surgery, and when can I get back to the gym?
Well, Samir, I like people to wear a collar for 6 weeks after the surgery, but you can not wear the collar at all. And oh, look at that herniation. That was literally in the foramen sitting on top of the nerve root. On the right side at C6-7. So I've been taking out like 5 big pieces of herniation so far that were all pinching the nerve on the right side, the nerve that goes down her right arm. Okay, that would be the C7. Let's see, this is 6-7, so C7 nerve root. Okay, and there's just more. You know, it's like non-ending. The good news is each of these look big, but they're not that big. They're small. This one's too big to come out, so I'm having to cut it. I prefer for you to use the collar 6 weeks. As far as going back to the gym, you can go back to the gym the next day after your surgery. You just can't lift heavy weight. You have to limit your lifting to 25 pounds. There's another piece of herniation. We'll just start a collection over there, okay? So we can look at it grow.
We have another question.
Look, I'm going to tell you something. This is the best surgery in the world for a herniated disc in your neck that's causing symptoms. But it's the best surgery in the world for you for 2 reasons. One, it's the least invasive, most effective. Number 2, we've never had a complication with this surgery, a surgical complication at all. Never. 20 years and 2,650 surgeries. Okay? Why is that important? Well, if you go have surgery, do you want to wake up and have a complication? Do you want to wake up with a problem like a paralyzed vocal cord or esophageal perforation? Well, I got news for you. ACDF, the most commonly recommended treatment by spine surgeons in the world, has a 50% complication rate. That means half of the patients will have complications. Why would you want to do a surgery where it's a coin toss to get a complication? Half of the patients will have complications. I wouldn't want that surgery. I would much rather have a surgery where there are no complications. If you think about it, what's the worst possible outcome of spine surgery? It's a complication, like an infection, nerve damage, spinal fluid leak, instability, recurrent disc herniation. All those things are complications. And the worst thing that can happen to anybody in any surgery is a complication. Complication happens 50% of the time with anterior cervical discectomy and fusion. It happens 25% of the time, supposedly, 40% of the time with artificial disc. It happens 25% of the time with PCDF, posterior cervical decompression and fusion. Why would you want to subject yourself to complications? You don't. I got news for you. You don't. Okay? You really don't. All right. So there's some herniation right there. It's behind the posterior longitudinal ligament. Look at that. Oh, it just came out. Did you guys see that? That was amazing.
Yes, we did.
That was literally sitting right on top of her spinal cord. By the way, most spine surgeons don't even go down here to take these herniations out because they can't see. They have no way to see. But with the endoscope and the laser, we're so precise at removing these herniations. Each of those blasts is 1/20th of a millimeter. Right there, 1/20th of a millimeter. Okay? Each of those blasts, 1/20th of a millimeter. That's how precise this is. That's PLL fibers, posterior longitudinal ligament fibers. You guys are seeing running left to right. The spinal cord is right below it. I don't see any more herniation behind the PLL. I'm going to come over here and look a little bit on her left side. Again, there's some more herniation, some scar tissue, some calcification. Look at the tear. You can see the torn PLL fiber right there. You guys see that? It's
Yes,
ripped right in half, right off. And that's how the herniation got out. Now this happens during trauma. So some type of trauma, vehicular trauma, slip and fall. Look at that big herniation, it's coming. Holy moly gosh, look at the size of that thing. It's so big, I'm gonna have to cut it in half because it won't fit out otherwise. So here we go, we're cutting it. The gold color stuff is calcium. That means it's been here a while, more than a year, that's for sure. Oh, there goes a piece right there. Oh, that thing's huge. Man, sorry about the sound effects. My wife tells me leave the sound effects out. But you know what? I just get so excited. Look at that herniation. We're going to deliver this like a baby. Instead of the birth canal, we're going to deliver it down the birthing canal of the scope. We call it a tubular retractor. It's a 2.8 millimeter diameter, internal diameter tube. External diameter 4 millimeters. Okay, there's another tear in the PLL right there. You guys see that?
Yes, we do.
This is all herniation. I've been blasting it, basically demolishing it into little pieces, which then float out towards me. You can't even see them, they're so small. That's amazing. Remember, she's a nurse. She works in healthcare, has for many, many years. She was funny. Like, she knew. She said, I watched all your videos. I know what you're gonna do. Just get it done. I don't have any questions. I love patients like that. They're like, they already know what they want and they're educated. The more educated and knowledgeable people are, the more they want this surgery. They don't want the other types of invasive surgery. All right, let's take some more questions, and then we already played the 30 causes of neck pain.
That we have, yes,
Yeah.
correct. Next is a comment and or seeking advice from Samir once more on YouTube, saying, I had a back surgery, doctor, 1 year back. The pain which used to trouble me day in and day out is gone.
Yeah.
I had with you is gone.
Good.
You are the best doctor. I have a neck issue too, so thinking of getting it done,
Oh,
saving up.
look at that herniation right there.
We could see it.
Look at that. It's like a snake in the grass. It just, it doesn't want to come out. But I'm going to get it. I'm not leaving with it still there. I'm going to make it come. Sorry, I like snakes, by the way. But the snake in the grass analogy is for a bat snake, like a viper. We'll just call it a poisonous snake, like a cobra. Okay. Cobras endemic in India. My God, so many cobra deaths every year. You know, Americans, we don't really think about snake bites and dying from a snake attack. But in other countries, third world countries, Africa, India, you know, where they're less developed and they have a lot more snakes living among people, those snakes kill people. Like, it's serious. Like in America, nobody really thinks about dying from a snake bite, right? But in other countries, people live with these snakes and they're horrible, like a cobra, king cobra. That thing will kill you. And they're mean. They're not afraid of people, those king cobras. They will come after you. All right. Bet you didn't know that I was a herpetologist. Something not many people know about me. I was very big into reptiles when I was younger. I've had many snakes that I've owned over the years, none of them venomous. I personally don't believe in keeping venomous snakes because if that thing gets out, and it kills somebody, how are you going to live with yourself, right? But I know there's a lot of really good venomous snake keepers nowadays, and they have really good facilities, but I still would never have a venomous snake. I like to play with my snakes when I had snakes. My first snake was a ring neck. Then I had a boa. It's called a Colombian red-tail boa. I've always preferred boa constrictors over pythons, personally. So this is all scar tissue right here. It's amazing, huh? Look at all that. There's still pieces of herniation locked away back here. It's unbelievable how much herniation there is. And then after my Colombian red-tailed boa, I bought an emerald green tree boa. which many people probably won't ever know what that is. It's one of the most beautiful snakes in the world, emerald green tree boa. And I was very lucky to find it because number one, they're very rare. But number two, they are mean. Mean. Normally mean. But mine was not mean. Mine was a beautiful, sweet snake. She never bit me once, ever. And I will tell you, emerald green tree boas are quite interesting for anybody out there that likes snakes. You see, snakes are very interesting. And by the way, what I appreciate so much about snakes is their evolutionary adaptations, for example. They are highly adapted to be successful in their environment. And if you think about it, most of the snakes that we have as pets are terrestrial, right? Terrestrial snakes. They live on the ground. And if you look at a terrestrial snake, many of them have, depending on their diet, they have like a lot of short teeth, right? Unless they're vipers, in which case they have these fangs, so they can inject poison into an animal. Okay, you guys following me? Okay. So the point I'm getting at is an emerald green tree boa lives in the trees, in the jungle, in the Amazonian jungle. And emerald green tree boas hunt birds. And birds, well, they've got a lot of feathers, don't they? So a snake, like an emerald green tree boa, cannot have short teeth. They have fangs. They're not poisonous, but they have fangs. Really, really long fangs, so that those fangs will sink into the feathers of the bird and grab the meat of the bird, not just feathers. If it just grabbed feathers, the bird will get away, right? Because its feathers are slippery. So you have to have fangs that dig into the meat of the bird. And that's why the emerald green tree boa is so amazing, is that it's got these long fangs. And why is that important? Because its disposition as a pet is terrible. It bites. Okay, some snakes bite, some don't, but this thing bites. Now I had one that didn't bite. That's why it was so special, because I never wanted to feel 2-inch fangs going into my fingers or my arm. Thank God it never happened. I was bitten other times by my Colombian redtail, and then I also bought an anaconda, a green anaconda. There's two types of anaconda, yellow and green. Green being the really big ones that get to be like 30, 40 feet long. I had a green anaconda, a baby green anaconda. Woo! There's a lot of herniations here, aren't there? That's why I'm talking so much. So, my God, a lot of herniations. This one's an old one, you can see. And the Brazilian rainbow boa was another snake I had. Brazilian rainbow. So that was my snake collection. I also had large lizards, from water dragons to very large Nile monitor. I had a 6-foot Nile monitor that I got from a friend who died and willed it to me. He was a neurosurgeon like me. Chris Kapashkin, miss him. He had cancer. And Chris's wish before he died was to have a large lizard. Okay? And his dream was to have a Nile monitor. A Nile monitor. So he bought it. I told him, listen, you buy it, enjoy it until you pass, and then send it to me and I'll take care of it. Okay? Otherwise, he wasn't going to do that, because his wife, Lisa, hated reptiles and would not let him have it. And she was worried he would die and then she'd be stuck with it. So I said, listen, don't worry about it. Just send it to me. I'll take care of it when he passes. So she did. One day I got a FedEx box and there was a lizard inside. And it was from Chris and Lisa. And my wife and I, she wasn't my wife at the time, but we took care of that lizard for years, fed it well. It got really big, 6.5 feet long. And I think I told you guys before, I kept it outside in a dog kennel. And one winter, the gardeners unplugged its heating pads and it froze. So I felt horrible about it. But that was the biggest lizard I ever had. Prior to that, I had water dragons. All right, I think we're done here. I'm gonna get one more piece of herniation over here, and then we're done. And then we're gonna move to the next disc, which is 5-6. Now 5-6 is different. This 6-7 doesn't have as much degenerative disc disease, like not as much bone spur, but 5-6 has more bone spur, it's more collapsed. I think she injured 5-6 first, and then 6-7 later. Like 6-7 more recently. She's probably doing fine with 5-6, you know, making it. And then when 6-7 happened, the cumulative effect was too much, and she had to get it fixed. So that happens to a lot of people. They have a smaller herniation, doesn't bother them too much. And then as time goes by, the herniation gets bigger, or they injure more discs, and they end up having to come in and getting it treated. All right. Any questions?
At this moment, no current questions, but we do have a comment coming from Ping on Facebook.
Hi, Ping. How are you?
Saying, always love tuning into the DLDR surgeries. You learn so much watching these videos.
Good. I'm so happy you do. That's why we broadcast these videos, as people to learn. And you learn by watching. You learn by asking questions. So while we're moving to the next disc, why don't we show the audience our how herniated discs cause so much neck pain? No. And how we can fix it.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debreeds the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Move up a little. Welcome back. You can see from our videos how the herniated disc will cause so much pain in the neck. By the way, take a look at all this pieces of herniation here. You guys see all this?
Yes, we do.
Some big, a lot of small. That's typical. Everybody thinks a herniated disc is just one big piece. It's not. It's many pieces. Shot? We're going to move now from 6-7 up to 5-6. We call this the Duke Spine slide or shuffle because we're sliding along the ALL. AP? ALL stands for anterior longitudinal ligament. Yeah. Shot? Okay, we're off to the right. I want to get back to the center. If you have questions, feel free to type them up. Sean? All right, we're in the center. You can see that. Now we're going to go up, lateral, up to 5-6. So I took the dilator out of 6-7 disc through the front, and then I slid up to 5-6. When I learned the endoscopic cervical technique from the Koreans in South Korea, Dr. Sang-Ho Lee, Basically, they only did one disc at a time, one disc. And I thought, well, I got lots of patients with more than one disc that need surgery. So what am I going to do? Bring them back and have multiple surgeries, or try to do it all in one surgery? Now, they didn't want to come back and do multiple. They wanted one. Hold on. Shot. So I had to figure out a way to do multiple discs with one surgery, lateral. And to do that, I learned how to take the dilator. Developed the technique of taking the tube out, leaving the dilator in, bringing the dilator up and out, and then sliding it. And there we go. So we can actually do up to 4 cervical discs during one surgery. Any questions?
Yes, we have a question coming from Samir once more on YouTube,
Samir!
asking, what's your opinion on endoscopic posterior discectomy? A lot of docs are doing it in our area, and I just want to hear your opinion.
Yeah, endoscopic posterior discectomy has been around for a long time. Many, many, many years. It's a terrible surgery. It doesn't work. It doesn't work. The only thing it helps, if you're lucky, is arm symptoms. It doesn't address the herniated disc. You're not removing the cause of the pinched nerve, which is the herniation. You're only taking the lamina and facet and out from the back. They are removing important bone that you need to hold your spine together. They are drilling away your facet joint. Show them the facet joint. Show them the herniation. See the herniation? Show them where the nerve is. It's right behind the herniation, right where the arrow is. Show them. Nope. Put the arrow to the left. Stop. Too much. Go to the right. The nerve is right there. Okay? The herniation is right there. The herniation is pinching the nerve. What these endoscopic posterior people do, move to the left. Right there. They drill all that bone out back there. No. They drill the bone out up and down. Up and down. All that bigger, bigger, bigger. Yes. All that bone out is removed in the back. And they indirectly decompress the nerve root, but they leave the herniation there. It is a shitty, bad surgery. It is like you have a cobra snake in your house, in your kitchen, and what you do instead of getting rid of the cobra is you build a new kitchen. That's how stupid it is. Why wouldn't you just go get rid of the cobra? Hire a snake catcher, pay them the money that you have to pay them, let them take the cobra away, and keep your kitchen. But don't build a new kitchen because you have a cobra in your kitchen. It's just dumb. The surgeons are doing the best they can. They don't know how to do what I do. If they could do this, they would do this. But this is a far more advanced, technically difficult, technically challenging. They don't have the equipment. They don't have the training. They don't know how to do it. I used to do posterior cervical foraminotomy 25 years ago. But we stopped doing it because it's so bad. The patients have all kinds of complications and problems. But those surgeons there, they don't care. They don't care that you're going to have problems. They just want to do the surgery because you're going to lay down and let them do it. They are preying on your ignorance and stupidity to let them do that kind of garbage surgery. It's like somebody telling you you have a cobra in your kitchen. You know, you should build a new kitchen. That's the only way to fix the problem. Leave the old kitchen and the cobra, leave it in there, and just go build a new kitchen. I mean, if you believe that, then you believe anything, right? And the problem is they're all telling you that. All these doctors are telling you the same thing. So you start to believe it because everybody says, build a new kitchen, build a new kitchen. Imagine if your car battery was bad. The battery was dead. Your car wouldn't start. And then they told you, you have to buy a new car, right? You're not stupid enough to buy a new car because you know. But that's what's happening. You people are all ignorant of the truth, and you just let these surgeons tell you, buy a new car. Your battery is dead, buy a new car. That's the only solution. We'll do endoscopic car buy. Buy a new car endoscopically, and that's the solution for a dead battery. The only reason you don't do that is because you're not dumb and you know better, because everybody knows there's a better solution. Well, 30 years from now, Everyone's going to know this surgery is the best solution, and they're going to say buying a new car when you have a dead battery is like having an ACDF or having a posterior endoscopic cervical foraminotomy. It's just dumb. Nobody will do it. But you guys got to evolve to that point, and you haven't evolved there yet. You're still believing all the lies they tell you. Organized spine surgery lies. Why am I getting so much water on my shoe? Did we turn the sprinkler on? I got 5 minutes, Dr. Burndead. So this is far more degenerated. There's the crack where the herniation went out. And the gold color is calcium. You could see there's no more herniation down there. All the pieces are coming out. But we're only looking at one small area. This surgery you're watching, Samir, is the future of spine surgery. The only reason these other doctors don't do it is they don't know how to do it, and they'll probably never learn how to do it. Okay? It takes a very exceptional surgeon to know how to do this kind of surgery. And a lot of doctors only do surgery that insurance will pay for. So they are doing whatever the insurance wants them to do. And remember, the insurance makes money when you don't get treatment. Okay? And if the only treatment available is a bad treatment, people figure that out pretty quick, and then they don't want that treatment, like ACDF or artificial disc or cervical foraminotomy. I don't believe any of the data on cervical foraminotomy. I think they're lying to people about the results. And it doesn't surprise me at all. All right, what other questions do we have, Henry? We got about 5 minutes left. These are bone spurs right here. Why is this nurse coming here for surgery? Why is she paying out of her own pocket for surgery with me? She could get foraminotomy. She could get artificial disc. She could have fusion. Why do you think she's coming here and having this surgery, paying out of her own pocket for this surgery? Why would the nurse do that? The answer is obvious to me. I hope it's obvious to all of you, because she knows the other surgeries don't work, and they're dangerous, invasive, and they fail. They're bad. She knows, and she knows there's a better option. That's why she's here. That's why everybody that comes here to Duke Spine comes here. They don't want to settle for garbage surgery of their spine. They're smart. Right, Luis? All right. Good questions. I love these questions, Samir. Good to hear from you, by the way.
Next few questions. Excuse me. Next question from Ping once more on Facebook.
Ping.
We
got about 3 minutes left. 3 minutes left.
Asking, when there is a tear in the disc, does the degeneration of the disc happen quicker? And after the DLDR, does this speed up degeneration, slow back down?
Hey, Ping, great question. I love it. Thank you for asking. So degeneration of the disc, folks, everyone's heard of degenerative disc disease. It only happens when you have a tear and a herniated disc. If you don't have a tear, you will never have degenerative disc. What is that noise? I thought Hector was voiding here in the corner of the operating room. I thought you were using the OR as a latrine, right? Hector's stream is not that good. No, maybe that's Hector on, what is it called? Flomax? Flomax Max, right? The new extra Flomax. All right. 3 minutes. You guys distracted me, so it's 3 minutes still. Yeah, like I said, folks, you're watching the most advanced surgery in the world. Every spine surgeon in the world will be doing this surgery in the future. The problem is they don't know how to do it. They don't know how to get paid for it. So they can't do it right now. Okay? That's a fact. But there will be no more fusions except for tumors that destroy the spine, or tuberculosis, something like that. There will be no more fusions except for fractured dislocations of the spine and trauma. That's the only time fusion will happen. Fusion will not happen in the future of the spine. Artificial discs will not happen anymore. Once this technology gets out and every doctor knows how to do it and they're getting the insurance company to pay for it, then everybody's going to want to do this surgery. Okay? This is the future. We see this all the time in medicine. Technological advances coming and changing the way medicine is practiced. Okay? For example, anesthesia. Many, many years ago, they used to just put people to sleep. They never secured their airway, and many of the patients would die of asphyxiation. And somebody said, why don't we put a tube down? And then let's control the airway. Let's ventilate them better, monitor their gases, and avoid, aspiration, right? Vomiting and sucking it into your lungs. So there's a lot of advantages of innovation, but innovation wasn't around in the caveman days. Innovation came around because somebody solved the problem, right? Patients dying of asphyxiation, patients dying from aspiration pneumonia, and somebody said, let's just put a tube with a little cuff. That way we can control their ventilation and we can avoid aspiration during surgery. So there was a technological advance. This is the same. What you're watching today, the Duke laser disc repair, is the most advanced way of doing disc surgery in the world. How do I know? Because I've done every other surgery. I know how to do all the other surgeries out there. I've done them in my career. I've done them very well. I know their maximum potential, what it is for patient benefit, and this surgery far exceeds on every front. Results, complications, recovery, functionality, everything that you can measure for a patient, this surgery is better. Okay? The other doctors don't want you to know about it because they don't do this surgery. They don't want to lose the business. They've got payments to make for their Mercedes. They've got golf memberships to pay for. By the way, those are expensive. All right, we're done. We've done 2 discs. We're going to just put some antibiotics and clean everything out. But her surgery went fantastic. We lost like literally maybe 5 drops of blood. And that was it. So, very good. All right, any other questions from our audience?
Just one more question coming from Samir once more on YouTube, asking, also there is a right side and left side for cervical like lumbar. Also, can we say that this will treat the weakness of the hand?
Yes, if the weakness of a hand is due to a pinched nerve at the back of the disc, like this patient had, then yes, the weakness of the hand will be treated by this surgery. All right, any other questions?
At this moment, no current questions.
We're going to just apply pressure to stop any venous bleeding, and then we're going to put a steri-strip in a moment, and we're pretty much done. So why don't you share with our audience one of our patients who recently had this procedure done.
Of course.
Dr. Duke Machen here at the Duke Spine Institute with a patient who traveled here from Colorado with her husband, and she underwent the cervical Duke laser disc repair for 2 herniated discs in her neck. And how are you feeling today?
Great. Even on the way home, I felt all the pain released from my arms and my shoulders. I didn't realize how much pain I was actually in. So my arms just feel light. And sitting in the waiting room here earlier, I realized my neck is not hurting at all and my headache is gone.
So your headaches are gone, your neck pain's gone, and your arms are starting to feel normal again.
Yep, yes.
Amazing, isn't it?
Yes, so amazing. I'm so grateful.
Yeah. Tell me what life was like for you before you came to Duke Spine Institute.
We have 4 small children and it was very hard because we homeschool. My oldest started taking over laundry. I couldn't get in to the washer to get the clothes out. He has to help a lot with the little ones with school. I was in bed a lot with pain and laying down hurt. So then I would sit up in the recliner and I wasn't sleeping at all. Last night I slept.
Congratulations. Now, are you feeling good here today because we gave you lots of pain medicines, or are you on any pain med at all?
No, I didn't even take ibuprofen. I think in the IV there was Tylenol. I didn't even take the muscle relaxer, no pain meds.
Yeah, the pain meds from surgery wore off yesterday.
Yeah.
And today your body has no pain meds and you have no pain.
No pain.
Congratulations.
Thank you.
Now, it must be hard with such a severe, debilitating neck and pain and headaches when you have kids because, you know, your whole life is all about having kids and bringing them up and engaging with them and being part of their life. And when you have pain like that, it takes your time away from your kids. It takes your quality of life away. So you had to do something about this.
Yeah.
And did you have any treatment in Colorado?
They wanted me to do an epidural in the neck because there was no room in the spinal cord. That made it worse because the fluid had nowhere to go. So I did that, and then the surgeon in Colorado wanted me to do a fusion and basically laughed when I asked if there was other options. So that's when it led us to do more research and watch all of his videos and know, I just knew in my gut this is where we had to come.
Yeah, you're right. I'm glad you did not choose the fusion, but why did you not choose the fusion? What were you worried about?
I was worried that I have 4 young children, and if I do a fusion, it would be worse, and then it would just keep continuing all the next discs. And I was really having like a claustrophobic feeling of I won't have any movement. I'll lose my mobility if I do a fusion.
And with the Duke laser disc repair, you can see we went in with a 4mm incision. There was no bleeding. There was no hospitalization. She was asleep for an hour while we did her procedure, and you basically woke up pain-free.
Yes, I was actually very emotional when I woke up because I was like, our whole family needs to come here. All of our parents are in pain, so this is where you need to come.
We'll take good care of them here. Well, share with the audience watching what life is going to be like for you now and anything you want to tell the audience.
I feel like when you're in chronic pain for so long, you start to have anxiety, have maybe a little bit of depression, and all of that has completely lifted. And I think doctors will be like, oh, you're just depressed, take this medicine. But that's not what it is. It's the pain, the chronic pain. So I know that my quality of life will be much better now. My 2 boys play hockey, and there were so many times I couldn't sit in the stands. So it's really exciting.
Congratulations.
So, yeah.
All right. Well,
Thank
enjoy your
you.
life with your family.
Yes, thank
All right.
you.
Let's get